morning, Salim. We are really delighted to have you with us today. And as usual, you have come up with big news in this meeting with Game Changers, a big trial, the Hope 3 trial. And I'd like to hear from your perspective on the impact for the cardiology, but also for the trialist community.
Well, as you know, Faiez, we asked three questions in the Hope 3 trial. The first question was whether giving statins to people at intermediate risk with no reference to lipid levels, what their effects would be. The second one was with respect to blood pressure lowering, using a combination of low doses of candesartan and thiazide in combination versus placebo, again without reference to blood pressure levels. This allows us to learn from this design how low you can go and treat and have benefit for both LDL and for blood pressure lowering. Trials where you have a cutoff where only people above a certain value get in don't tell you what you do in the rest. And the reason for this is the types of people that we got in represent the majority of people in whom there's a question mark on primary prevention. So what we found was that the use of statins had a clear beneficial effect on heart attacks, coronary revascularizations, heart failure, strokes, and a trend towards cardiovascular disease deaths, so that the composite of these was highly significant. With blood pressure, we had a rather interesting finding. Overall, there was about a 7% risk reduction in the composite endpoint, with strokes seeming to be a bit more reduced at 20%, but was not significant. But the interesting thing is in a pre-specified subgroup analysis, which everybody will say it makes sense, is in those with the highest blood pressure, the upper third, there was clear benefit. Those in the middle third, blood pressure lowering appeared to be neutral. And those in the lower third, which is usually a blood pressure around below 131, it was actually tending to be harmful. It wasn't significantly harmful, but tending to be harmful. Now, the blood pressure lowering was the same in people at the highest level, the middle level, and the lowest level, indicating that the differential effect by blood pressure was entirely due to differences in baseline blood pressure and not due to differences in the degree to which blood pressure was lowered. So that has important implications. What this means is in people with hypertension, and these are mild hypertension, stage 1, but there's still some controversy, you would use low doses of 2 blood pressure lowering medicines along with a statin, and then you get a 40% risk reduction in cardiovascular disease. That's big. And in the others, you only use a statin and you get a 30% risk reduction. And the regimen we used was very simple. We didn't identify people through complicated tests. When they received these drugs, there weren't a lot of safety monitoring. The visits were initially after starting at 6 weeks, then every 6 months for the next 6 years. So it's not onerous, it's simple, it is practical, and it's low cost. And finally, both medicines were relatively safe. The only safety issue with statin was more muscle pain and muscle weakness, but that's 1% excess, and when you stop it or reduce the dose or give it alternate days, it went away in the majority. And with blood pressure lowering, the only side effects really was lightheadedness, but no syncope or acute kidney injury. So what we've shown is a simple, widely practicable strategy can help millions of people worldwide.
Can I ask you another question? Because this programmatic trial, the virtue is that you can take them immediately to your clinical practice. And now the definition of the population, intermediate risk. So what is the kind of patient who would walk in my office that I would qualify as intermediate risk?
Well, we were targeting people with an annual risk of 1% per year. So we used an age cutoff. And we used 55 for men and 60 for women, but the concept of older age, middle age. The second thing is they needed one other risk factor, and it could be obesity. 80% had abdominal obesity. Could be low HDL. It could be a history of smoking, a family history, dysglycemia. And I would imagine that once you go past 50 years, 75 to 80% of the population around the world actually would would qualify for this trial. So it's, most people.
So in a way, in the factorial design, you didn't really test the hypothesis for polypill, but
Concept is.
the concept is there because some patients end up by having a diuretic, an ARB, and a statin.
And it's a mini polypill.
Yeah, so how far are we from applying this to the polypill concept?
I think we are ready to apply the polypill concept now to hypertension. It also says the polypill concept may not be valid in primary, may not be applicable in primary prevention without hypertension, where just giving statins would be helpful. In secondary prevention, the evidence is so good that all the components of the polypill saves lives that it would not be practical to do a trial of the polypill versus placebo. Of course, you could do polypill versus usual care, and there are trials going on that way. We have another trial of the actual polypill where we're giving 3 blood pressure lowering agents at higher doses and a statin versus placebo. We're trying to get 4,000 people. We have about 3,500, and they're higher risk than this group. That trial will take about 2 years or so to give us an answer, and it is possible that the results may be clearer because the blood pressure in that trial is about 8 millimeters higher than in this blood trial. So they're higher risk people.
Well, I understand that this polypill concept is something lots of geographies would take, but now in the FDA and Europe, they have some reservation about the approvability, the track to approval.
Actually, the polypill, Ferrer has a polypill that is now approved in many European countries. So I think the uptake is increasing. In the US last year, the FDA had a meeting on this, and they gave a very simple track towards approval of a polypill in secondary prevention, and they are open to a polypill in high-risk primary prevention. So I think the regulators have come around. Physicians are beginning to come around, and I think the HOPE-3 study will help. They wanted the evidence. So I think in 1 to 2 years, I would see the uptake of the polypill worldwide increase because now we have at least 2 polypills that are approved. The Ferrer polypill in Western Europe and in South America, the Indian polypill, Cadilla's Polycap in India and in Africa, and they will likely be applying. And based on these results, AstraZeneca, who were the funders of HOPE-3, are thinking about the possibility of developing a polypill just using these 3 components. And I know a lot of manufacturers are developing the polypill.
One final question. Cardiovascular clinical trial is about CVCT community. So what message would you give to the community on the design of future trials? Because you have been pioneering these large, pragmatic, simple, but widely applicable trials, whether this is a trend which would last, or what would your advice to the community?
I think the things to notice about our study design is the fact we didn't have strict entry criteria. We said, we used what is called the uncertainty principle. If the treating physician, primary physician, is uncertain whether or not to use the medications we were testing, they get put into the trial. Because uncertainty varies by country, by physicians, so that really reflects what is happening in practice or what is not happening in practice. The second thing is we wanted simple regimen because complicated regimen where you're force titrating doses, especially a blood pressure lowering drug, it requires frequent visits, it causes a lot of side effects like in the SPRINT study, and its applicability may only be to a narrow group of high-risk patients in specialist settings. So therefore, the pragmatic approach was widespread. But there was another design issue, which was the factorial design. The 2x2 factorial design allowed us to answer 2 questions for the price of 1. But interestingly, because both questions we were interested in, it answered a 3rd question, which is what does combination therapy do versus neither or versus either? So that's a 3rd question. And in fact, we're now analyzing the data to look at a 4th question, which is what does statin alone do versus blood pressure lowering? Not that it is either or, and the reason for this is people have emphasized, especially from the epidemiology, that elevated blood pressure over 115 is the biggest cause of mortality and morbidity in the world. Today we know that's not true. It's actually lipids that are the main cause, and blood pressure is important, but only if it's in the hypertension range. So this study has answered so many questions, and I would say from a practical point of view, our approach at the PHRI is always to consider a factorial design, unless it's not possible. Okay, unless it becomes too complicated, or the sponsors don't agree, or there are interactions. And I must say, 3/4 of our trials are factorial designs. And it's so important because, you know, the amount of work that goes into a trial like this was 12 years of work. You know, it's important we maximize the utility. The last thing is we hardly had any monitoring, just random monitoring and monitoring for cause, and the amount of money we spent on monitoring was less than about 2% of the budget of the study. You know, and the overall study costs were extremely modest. Now, of course, part of it was the design, but part of it is the fact that the company kept out of it and let us run it, and the investigators believed in the question. I don't think you can do this for new molecules because you need a lot of safety thing. But there are important questions that go beyond getting approvability, and this is one of those trials.
Great job. Well, what are the virtue of the factorial design? It may get you 3 papers at once in the New England Journal of Medicine.
That's because there were 3 important questions.
Thank you and congratulations.
Thank
Good
you.
job as usual. Thank you very much.
Thank you. Thank you, Faiez.